Thank you very much. And thank you, Dan, and thank you, Shrinik, for that very kind introduction. It's not really me, but the team that, and you've seen that yourself. It's the team that does most of the hard work. I just sit on the table and order people around, which after a certain age you're allowed to do, aren't you? So today I'll be speaking to you guys on community engagement and involvement and its relation with pediatric surgery, both here in Ludhiana as well as different parts of India and we hope to expand our work a little bit in South Asia right now. Um, I bring greetings from Ludhiana. Shrinik and his team has seen this. Ludhiana is a city which is almost in the center of the road from Delhi to the border towards Pakistan. Ludhiana historically was on the what was then the Grand Trunk Road, through which Rudyard Kipling's Kim traveled up and down all the way to Afghanistan and the other way to Rangoon. Um, the Grand Trunk Road, like a meandering river, has now moved away a little bit, so it's not right in the middle of Ludhiana anymore. But we are still very close. Ludhiana is was actually the last outpost of the British before the Sikh Empire started across the river Sutlej. But now is a large industrial city with a lot of machine tool works, a lot of manufacturing of cycles and woolen clothes, etc., um, happening here. Um, so the population in Ludhiana is a very shifting population because there are migrant labor who come to work in the factories here, but then go back to their families and their hometowns and states when there is the harvesting season or the sowing season. So we would have anything from 20 to 30 million people in the city. And the city is not a very big city, but it's a fairly crowded city. The second picture that you see is a road right opposite the hospital. So getting to access to the hospital can be a major challenge at times. But we know how to cross roads in India very well. Something that we taught Shrinik as well. Um, this is the medical school that I work in. This is a medical school and hospital, Christian Medical College, Ludhiana. A lot of you must have heard of CMC Vellore, which is better known. I did my training from CMC Vellore, but CMC Ludhiana is actually older, and we like to say we are the original ones. It was built as a women's Christian medical college. Ludhiana was a predominantly Muslim area, and the women were behind the parda at that times, and were not, and male doctors could not access women. So this lady from the Lake District in the United Kingdom came over here to try and change that in 1894, and then went on to make the first women's medical school in Asia, which admitted only women till 1953. And after 1953, men came in and standards went down, I think. Um, but no, so we are a 700 bedded hospital. We give both undergraduate training and postgraduate training and subspecialty training in specialties like pediatric surgery, etc. Um, right, why community engagement? For a long time, if you look at pediatric surgery, and for global health, I think surgery was an orphan child of global health and has been for a long time. And pediatric surgery, actually, nobody really talks about. Children are not very important in the larger scheme of things that policymakers, especially in my part of the world, think about. Community engagement actually was important to bring surgery into the public health domain. If things have to change on the ground, especially in surgical specialties, it has to be through public health, and there has to be a marriage between public health and clinical medicine, and in this case, surgery and pediatric surgery, because it is important to build trust and empower local communities to ask for the healthcare that they deserve. And I strongly believe that for any government, the basics that they can give to their population is healthcare and education, and that should be a given. But unfortunately, in large parts of our world, that is not, and we see that every day, and we see what's happening in our world today. Um, it doesn't seem to be very important to policymakers to keep people healthy, safe, and educated. Um, Local communities are the major stakeholders in everything that we do. While we might feel very happy and sit prettily in our offices and our wards and our operating rooms, it's the communities that are the major stakeholders, and we can never wish them away. Which, for long periods of time, especially in the global south, they have not been considered important. And that's the reason that we have to work with communities to integrate surgery, and in our case, pediatric surgery, into the public health domain. Early surgery is a good thing. It saves more lives than vaccinations can do, which is documented fact. Late surgery is a bad thing. So it is extremely important that we work in the public health domain rather than staying in just in our operating rooms, because we have to meet the underserved needs of our real world. 60% of the population, or maybe even more, lives in the global south. A fairly humongous majority of surgery still happens in the global south, and our countries and our communities deserve more than what they have been given in the past decades. So, just a few facts. We give to the world about 23 to 25 million births per year. Might not be a surprise to you. We are we have there are a fairly large number of Indians in India and around the world. Canada is probably can say that. We we have about 400 million children below the age of 14, and in many centers in India, pediatric surgery now moves on to 16 years of age or even 18 years of age. So there are a fair number of children that are there. 5 years ago, we were a fairly young population. We are getting a little older, but still we have a lot of children who need support. The incidence of congenital anomalies is 18.2 per thousand live births, and 2% of neonates born in my country require surgical care. And surgical conditions on a whole contribute to one third of childhood deaths. And the stark reality, a lot of that are under five deaths. So children at what we say at the dawn of life die because they did not get adequate surgical care fast enough. Um, we are about 1,800 pediatric surgeons. We need double the number of pediatric surgeons in India. Some of us train and then go to other countries for various reasons. But the fact remains that there's only one pediatric surgeon per 300,000 population in my country. And most of them are concentrated in urban areas. So that statistic is not completely right, because you will see a lot of pediatric surgeons in cities like Delhi and Mumbai, but you will not see pediatric surgeons in our remote areas, in our rural areas. So, in our community health centers, which is the second level of healthcare that happens in India, that is the district hospitals, there's an 80% shortfall of specialists, especially pediatric specialists, such pediatricians and pediatric surgeons. Most rural hospitals cannot provide basic pediatric surgical care. That includes trying to do a neonatal colostomy. They are not able to do that. There is hardly any pediatric anesthesia service available in our community health centers and our rural hospitals. That's another constraint which doesn't let surgeons do surgery on children, because there's no pediatric anesthesia, and of course the lack of NICUs and PICUs. And even now, a bulk of the work in rural areas in pediatric surgery is done by adult surgeons who might not have any particular training in pediatric surgery. Um, there is that concept that children are young, are small adults, which we all know is all rubbish. But that's how things work. That if you can do an adult colostomy, maybe you can do a neonatal colostomy. But the nuances of what should be done in a neonate are not understood by the surgeons who are taking care of these children, and that's no fault of theirs. It's just they are the only people available. So, and in pediatric surgery training positions. About, I don't know how it is in Canada, about 75% of pediatric surgery training positions in India are vacant. We are not a rich specialty, which is probably true for everywhere around the world. People like work-life balance. I think that's a buzzword nowadays amongst younger people. And so pediatric surgery can be extremely intense and does require a lot of effort. And I think a lot of people don't want to put in that effort anywhere. And of course, there's a healthcare coverage gap. Universal healthcare is still not fully available in my country. Private insurance might be available to about 10 to 20% of my population. Things are getting better there, and hopefully in years to come, we will have universal healthcare. But the fact remains that the sustainable development goals when it comes to pediatrics will not be achieved by India by 2030. So we are already way far behind, and we are not going to get there. So the objectives of community engagement would be to deliver care, decrease access gaps, and access is not necessarily distances, it's just where to go in the first place. Eventually, to improve outcomes, decrease expenditure. A lot of out-of-pocket expenditure happens in my country, even with government, even in public hospitals, which are supposed to be free. Then we collaborate with local health workers to upskill them and give and empower them, support surgeons who are working in rural and remote areas, and engage communities for better care. And these are the objectives that are there for community engagement. And our strategies are what we have figured out right now, and we might not be right, but this is what we work on right now. And hopefully this is something that we continue to develop way beyond my working life so that we are able to give better care. So our strategies are to deliver care, increase awareness, and continue with research. Some pictures, and this is what we work on. This is our work in community engagement. This is just a drop in the ocean. There are a lot of people in India doing a lot of good work, and so we just one of those people. But I'll give you some pictures of work that we've done in India and in Bangladesh. Some of these pictures are from Bangladesh, where we work in a remote area northwest of the capital city of Dhaka. And then we work in central India, in the state of Madhya Pradesh, then in the northern mountainous areas in Himachal, right up in bang in the middle of the Himalayas. Fairly stark scenery there, impressive scenery. But if you look at if you look at these pictures, you might balk at these are operating rooms. These are not verandas outside. So these are operating rooms, and you might balk at what we have available compared to what you would have available in a high income country, even me in my medical school. So these are the constraints that we have to work with. These are some of the camps that we do. When we do these camps, it doesn't mean that we operate and walk away. We stay there for about 2 to 3 weeks, taking care of post-op as well. I detest the fact that what used to happen in some sort of a colonial hangover, what we call parachute surgery, when people from the West would descend, do surgery, and then walk away, while the local people would be left holding all the complications. So we try not to do that. We only go to hospitals and do clinical work where there is a surgeon available who we try to empower and skill so that he or she can take care of most of these patients beyond the time period 2 to 3 weeks. What we look at that we should not have any complications within the first month. So in some ways, we have to be very precise now. So there are resource constraints, there are constraints in equipment. A lot of places we have to operate on children with adult instruments, um, but we have to get it right the first time round. Because if we don't get it right the first time round, it becomes a cycle that keeps going on. There are complications can't be handled. We might not be there. They will not get care. So we have to be very, very precise. So it's very, very important the way we choose our patients, who we are going to operate, who we are not going to operate. There is a lot of work now. The place I go to in Bangladesh, in a week, I would probably do 5 to 6 bladder extrophies. So there is a huge need that is there. So you have to balance that need with doing excellent work or a precise work so that you don't have complications. Try and decrease the number of complications that you have. You'll never be zero, but you try
Um, we can't hear you. We cannot hear you, Dhruv. Suddenly.
Hang on.
Yeah, now you're good. Now you're good. Now you're good.
Okay. All right. It is the internet. Okay. Can you hear me now?
Yeah, yeah.
Okay. And then this is some of the equipment constraints that we have. These are we don't get disposable gowns and drapes and everything, so these have to be washed, autoclaved. It's regular towels that have been used. Some of them have holes, some don't. But you work with what you have, really. This is not the place where you can complain and expect things to be absolutely hunky dory. They won't be. Uh, Sometimes we carry our own instruments, and sometimes we have to work with adult instruments. I think laparoscopy, in some ways, can change a lot of things in these hospitals if it is available, because it will decrease the amount of surgical site infections, which is the biggest killer for patients who undergo surgery in these areas. We look towards seeing whether laparoscopy will become more prevalent in some of our remote areas. While our cities are full of robots now in India, I think we will probably have more robots in, I don't know, we have got 4 robots in Ludhiana right now, which is not a very big city, so you can imagine. But I think what will happen in the future is laparoscopy will move into the remote areas, while the fancy robots can stay in the big cities. But laparoscopy will be extremely useful in many of these hospitals. You see funny things in these places, stuff which I would not see in my usual practice. And my specialty being pediatric urology, it's a every day is a day of discovery for me. Things like, female hypospadias, which I probably would have seen once in my lifetime. I get to see a few of them every time I go. Late bladder extrophies, etc., etc. And at the same time, when we go there, we just don't operate. We also upskill. We try and give training. So training not just in surgery, but training in post-operative care, training to the nurses, training to the lab personnel that are there, so that we can get better blood reports, etc. Improve their capability to do what more than what they are doing there, and we skill ourselves. So if you look at the last picture there, that last picture is a colleague of mine who's learning how to do cleft work. We're not taught in our training to do cleft lips and palates. So here's Vishal there, learning how to do a cleft lip, and this is his trainer, who's actually a urologist, but an adult urologist, but also does cleft lips and palates, and does a very good job of them. So, so that's how we have to work in many of our rural areas. You generally are not removing prostates, but you might be fixing cleft lips. So that's how things work in India. The second part of community engagement is awareness and increasing awareness. And we've just now embarked on a program with the government here to train medical officers and community health workers in the nuances of both identifying pediatric surgical problems and other pediatric problems, to develop a care pathway, see what they can manage in the primary health center and what needs to be referred quickly and where to be referred. So, what we are trying to develop in the state is a care pathway for pediatric surgery, so that the patient goes to the right place at the right time and does not get delayed going around in circles. Um, and we've now started making these little cards and pamphlets, which we distribute in communities. We go to villages, we distribute it amongst the people living in villages, in slums, in semi-urban areas, and with to the community health workers. Now, these ladies in pink or shades of pink, are the backbone of Indian healthcare. If the COVID vaccination was so successful in India, it was because of these ladies. They are paid a pittance for what the work that they do, but they live in the communities. They deliver healthcare into the communities. They are primarily supposed to deliver antenatal care, maternity care, vaccination, but now we are skilling them to actually take care of patients who've had surgery, children who have had surgery, to identify congenital problems in children, to look at things which would indicate that this child might be having a cancer, either a solid tumor or a leukemia, and tell them where to go. So they are the people who are going to make our care pathways successful. And this is our biggest program right now. I think we have trained more than about 5,000 community health workers across 3 states in India, and it's growing. And if this program becomes successful, what we envision is that we develop a care pathway for pediatric surgery, and pediatrics and children can get to a surgical hospital much, much faster than they are doing right now. So we would not end up with somebody with an anorectal malformation actually coming to the hospital with a perforated colon or a perforated cecum. That's what we are looking at here. Um, Lots of them. The communities have been great. We do these things in temples. We do these things in gurdwaras. We do it under the village banyan tree. We travel with our own mics and speakers. Tea making material, tea, milk, water, everything. Some of my team, they make the tea and distribute while the others are delivering the training. It's been a gratifying experience. And with the community health workers, what comes in are the people from the villages and the slums. They also come in. So it's not necessarily this the community health workers who are sitting here. It's the entire village which might be sitting there listening to how to take care of a stoma in a child. So very, very gratifying experience here. So our work now is spread across 3 major states of India. That's Punjab in northwestern India, West Bengal, and down south in Tamil Nadu, where I trained. This is an old number, but we've now gone past 5,000 in Punjab, in the areas around Vellore and the areas around Kolkata or Calcutta, which was known earlier. And 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 this is something that now we are working with the National Health Mission in the state of Punjab. Our next step is quality improvement. We are at the same time looking at improving quality both in the operating room, pre-operatively and post-operatively. And the thing that we're running with Lifebox, which is a charity from the UK, is called the Clean Cut program. We are running across the country in 10 hospitals right now. And we are also collecting data in a sort of a step wedge cluster trial, um, to see how we can improve quality within the operating room. And that starts with doing the surgical safety checklist. When we started our research work in 2018, I think the penetration of the surgical safety checklist in most hospitals in India was about 20 to 30%. It's great to see that over the last 6, 7 years, this has gone past 70%. And these are small, small steps that people have taken to improve things in our hospitals, in our operating rooms. These are some pictures of our various training programs in quality improvement in the post-operative ward, within the theater, peri-operatively, etc. And a lot of that work, while I'm there, I probably have not delivered the training. A lot of the training has been delivered by our research associates who seem to have grasped the nuances of quality improvement in surgery very quickly and very fast and do a wonderful job. One of the things that we learned, it's probably best not to ask the surgeon or the doctor to deliver any kind of training because we go into technical jargon which nobody understands. It's best to ask a nurse to do that. The communities relate to the nurses very well. Nurses can dumb down things, and nurses have a very good way of following a set protocol. Um, I don't know how it is with you guys, Dan, but with me, I go off on a tangent most of the times. So everybody needs to keep getting me back on track. Um, and then the final pillar, research. A lot of research that came out from India used to come from big cities and big hospitals like the All India Institute or CMC Vellore, etc. The voices from our rural areas and semi-urban areas where a large part of our population still stays were never heard. They weren't Lancet would not talk about them. New England Journal of Medicine would not talk about them because those papers came from All India Institute in Delhi or some hospital in Mumbai. What we've been able to do with this community work is bring research to the small rural one surgeon hospitals. We've set up research infrastructure with research associates, etc., so that the surgeon doesn't really have to collect the data, it is collected for him. But we brought that out, analyzed it, and we've been able to publish a lot of our work in good journals. But a lot of that data has come from very, very small hospitals and remote hospitals where DHL and FedEx say, don't go in this hospital here where this group is sitting. We tried to send some paperwork there, and DHL returned everything saying that this place does not exist. Um, so so that's and these are some of the studies that we've done over the years. The gratifying thing is not that we've done these studies. The gratifying thing is that all of these studies have also been done in our rural hospitals. So it's not just in big hospitals like CMC Ludhiana that we've done it, but this has all happened in our rural hospitals. So that is the biggest thing. I'm not really sure of any other specialty where they have been able to do so much research in our rural hospitals. So remote in India is very disparate. It could be this, it could be this, and we are countries within a country. So when I say remote, you're not really sure what you'll get if when I say remote in India. Um, the things that we see beyond surgery is great. It's always a good idea to do your to plan your programs around your birthday. So somebody will bake you a cake in one of these small hospitals, and those cakes are extremely tasty. Um, you see different versions of English. This is the first time I've heard service being spelled like that. And you will see communities have become so self-sufficient. So this is a hospital which also has a school. This is a very remote hospital, also has a
Wow.
school, also has a piggery, has a dairy and everything. It's a self-sufficient community which is developing around the hospital. And that's how things will work eventually. There are beautiful days here. The mornings are just great before you go to work. So it's extremely gratifying to go back, go to these hospital, and of course you always get to go back home. That is Bashar. He and me are been together for a long time. Bashar comes from Jordan, actually comes from Palestine, but poor fellow can't go back to Palestine. But we travel a lot. He works in Qatar, but he comes over and does stuff with us. We are getting back from Bangladesh. These planes sometimes take off, sometimes don't take off. Um, Fortunately, the ones they've taken off, they have landed, so I'm able to talk to you. So thank you very much for having me. And I hope this just gives a small glimpse of what we are able to do. And again, like I said, this is a drop in the ocean. There are lots more things to be done, and a lot more people doing lots more things around the world. Thank you.